forwards but downwards almost, which means that that supraspinatus against the glenoid resolution is now not as it should be. Perhaps that leads to problems of chronic activity in the muscles that stop downward displacement. We then go into adaptive shortening of the pectoral muscles, the major and the minor, with corresponding weakness of the interscapular muscles. Now, there's a relationship obviously between the temporomandibular joint and the cervicothoracic junction and the craniovertebral area, because if we take the jaw or we take the head forward like this, it takes the jaw out of its 4-7 position and pushes it right back into the sort of 2-3 or whatever these positions are called, very much back in the fossa. And the structures at the back of the temporomandibular joint are the elastic tissues, the vascular tissues, and so on. We want the jaw a little bit forward on the articular eminence, not back, right in the fossa. And if I get into this position, because of the tension of the suprahyoid muscles, all of this gets pulled backwards. So this is not good. So all these patients that go and have mandibular repositioning devices and nobody mobilizes them, I think it's probably a waste of money, and perhaps even makes them worse. Because here we've got the splint taking it forward, the body's calling it to come backwards, we've got a stress situation before they start, and presumably we're going to have even more of a stress situation in the long run. So there's a relationship. How about the relationship with the pelvis? This is one that's been observed, and I think Anne spoke about this in the 1984 IFOMPT Congress in Vancouver, that we look at the relationship of this position, and we look at perhaps the sacroiliac joint position, and we feel it, and we ask a patient to come back into more of an axial extension, which is our classical testing position, isn't it? Can you get back into that position? If we're on the lumbosacral or the sacroiliac joint, and that gets worse as we come back, it means that this is probably compensatory for the sacroiliac joint. And the thing to do is to try and fix the sacroiliac joint. On the other hand, if when you come back it kind of corrects the pelvis, it means that the asymmetry we're seeing in the pelvis is secondary to this. So we should be correcting this, and the pelvis will just correct itself. So sometimes we see these relationships quite remote and probably very intimately related to alterations in our postural mechanism. Who knows what they're all caused by?
Are you checking PSIS there?
Just the posterior, the PSIS. And have the patient in sitting and in standing, and just have a look at, see if a balance comes back, and it looks as if it goes back more to a corrected position. Now then, as well as all of this, the last one, yes. And I shouldn't miss that one, should I, Chris? This is from one of Chris's countrymen, Orsendorp. Okay, that's why it's in purple, so that we don't miss it. Okay? This is sympathetic hyperactivity to the head and neck. Dr. Orsendorp has done a lot of work on this particular area, and he presented a paper in to the IFOMPT meeting in Cambridge in England on this particular topic, in terms of activity in the vertebral artery related to sympathetic activity in the upper part of the thoracic outflow. And it was really quite an interesting lecture. And I asked a question which was a little bit kind of not very clear to Dr. Orsendorp. So he's asked me questions ever since at meetings when I've been speaking that haven't been clear to me. Okay, so we've got this kind of one-upmanship going on at the moment. I didn't mean to be rather obtuse. What my question was is this, that if we have a dizziness, let's say, created by this rotational position, and we mobilize the thoracic spine, and we find that this improves, has it improved, or can we say whether it's improved? Because mobilizing the thoracic spine means that when I do that now, the mobility of the thoracic spine is added to this linkage and improves the situation. Or have we reduced activity in the sympathetic system by mobilizing the thoracic? I kind of would have liked to have thought of the second one because it's more exciting. It's not a mechanical reason, it's an actual neurological reason that we've reduced sympathetic tone here so that when they turn, we haven't got quite so much activity, presumably in the vertebral nerves. And his feeling was it was the latter reason, that we've been able to cut down sympathetic overactivity by treating this, so that when we turn the head now, that sympathetic activity is being reduced and we don't create so much tone in the vertebral artery. The problem with that is that some of the experiments that have been done by Stilwell and also experiments that have been done and reported by Bogduck tend to refute that. He says that the vertebral nerves, which are the sympathetic nerves in the tunica adventitia of the vertebral artery, are very, very non-active. And they haven't been able to produce very much activity in monkeys by all kinds of stimulation in the vertebral artery as it runs through the foramen transversarii. However, Dr. Orsendorp had no doubt. And since I read Bogduck's work, I asked him the question again. But now we're drinking over beer asking each other questions, so it's kind of a little bit better. All right? So, and he still feels that this is a very important thing. And he did a lot of Doppler ultrasound, measuring the rates of flow through these arteries and everything. So I think we should take this, however it works, and hopefully it works by a reduction of sympathetic hypertonus. But even if it only works by increasing the mobility of the neck, certainly Dr. Orsendorp's patients that were dizzy got less dizzy when he'd treated this area. So it's really important that we do it in terms of many reasons. So here we've got a setup, absolutely perfect for chronic and repetitive strain injuries. We could add a further parameter or dimension to this if we look at some of Chan Gunn's work from Vancouver, who's been talking about prespondylitic neuropathy. And what's meant by prespondylitic neuropathy is Chan Gunn reckons that there are changes in the nerve conduction in joints that are starting to show spondylitic changes, or perhaps haven't quite got to that stage. But they're at a stage in the patient where you feel measurement shows that there's some dysfunction. And it shows up as a number of things. Hyperactivity in the nerve leading to key muscle hypertonus. It leads to paravertebral muscle spasm, which is part of what we are considering to be the tissue textural abnormalities. He also says, and this is a very important thing, and I don't know whether this is proven or not, but it leads also to collagen degradation. So here we've got an ideal setup, let's say for a tennis elbow, in a patient with this kind of posture, that we've got prespondylitic changes, they're kind of working at a machine and pulling stuff through. They're getting this neuropathic pain syndrome, which is giving them, say, hypertonus in the C6 originating muscles. They're getting degradation in the collagen tissue, making up the common extensor tendon. And they're keeping on blasting this by the action that they're doing and the position that they have to work in. So this is a really important kind of area to treat in terms of its total conceptualization. And I think it's rich for a lot of excellent treatment by us. And I don't know how many people treat this very well. And I think we should be treating it the best of anybody. Complicated by this is this business. We've got the thoracic outflow here. And we've got the relationships between the first and second ribs, the brachial artery and the vein, the scalene muscles here, particularly the T1 root as it gets prized over the first rib and into the arm. So this is very important. And also, when we kind of look at the brachial artery or the subclavian artery here and then the brachial artery here, of course, it's coming up underneath muscles such as the pectoralis minor, which are tight because of this syndrome, which might lead to the hyperabduction type of thoracic outflow. So, the whole of this area is so nicely or pathologically or dysfunctionally linked together. Yander has addressed this, as you know, and he calls this the upper crossed syndrome. There is imbalance in the following muscles, and we've mentioned these mostly, between the upper and lower fixators of the shoulder girdle. The upper ones, such as upper fibers of trapezius, levator scapulae, and frequently the scalenes, they go tight. They act in the same way as postural muscles. And the lower ones, such as lower trapezius serratus anterior, act as phasic muscles, and these weaken. So we've got a real imbalance in the way that the scapula is being held, which means now that all those muscles that work from the scapula to the humerus are all in a very, very difficult situation. No wonder we have a lot of problems treating chronic impingement syndromes of the shoulder, because we can't treat anybody over 40 or less than unless we're doing a lot of work on the upper thoracic spine. It's an impossibility, because they've all got this, and if they've got that, they've got changes in the shoulder girdle, and if they've got changes in the shoulder girdle, they've got a reduction in this height, and if they've got all of this, they've probably got this going on. There's a fundamental difference between the tensions and the tone of pectoralis, both major and minor, and which tighten, and the interscapular muscles which weaken. Okay, so now we've got the patients here. Pull your shoulders back. They try that hard and they kind of end up like this, but this is not very well done, which is a good thing probably, because then they have to go back to this position. So the stretching and the tension of the pectorals, that's all going to be part of this. This is not a quick little flick and away, thank you very much. This is a very big, comprehensive treatment that we should be doing on this area. You look at the deep neck flexors. This is the crossed, back and front of different things. The cervicis longus, the longus capitis, and thyrohyoideus are weakened on the one hand, and the neck extensors, pulling the neck into a lordosis, are tightened, and particularly those suboccipital muscles, which are tightened and very reactive, which are part of screwing up the whole of the postural mechanism. In addition, there may be shortening of the uppermost part of the ligamentum nuchae with a fixed lordosis in the upper cervical region. I think, Bill, if you've got a lot of these, you'll be treating them for the rest of their lives. I should order your Mercedes on Monday. Good. I was telling Bill to order his Mercedes on Monday. This one here, that in addition, there's shortening of the uppermost part of the ligamentum nuchae and fixed lordosis of the upper cervical region. Just doing manipulation is so inadequate, isn't it? That's why we do all the other stuff. But it doesn't alter the fact that manipulation is still, for when it's necessary, the best way of going about things. And perhaps we can spend then more time on patients that need all of this stuff. Yes, Sandy?
Number 3 is saying that the deep neck flexors are
Weak. Yes. And the extensors are tightened and shortened.
But all the other things are in the opposite order.
Oh, okay.
Okay.
Yeah.
So I just wanted to be clear.
Yeah. He's giving the weak one first there. That's good. And all the others giving the tight one first. Yeah. So obviously, looking at this last paragraph, if the lower fixators of the shoulder girdle are weak, the upper fixators must become hyperactive and tense. Something's not going to allow the scapula to sort of float around. And so we tend to sort of overcompensate, and unfortunately this produces all kinds of alterations of the shoulder girdle and then of the thoracic outlet. And what do we have? Treatment of a thoracic outlet, shoulder shrugging exercises, please. What a lot of rubbish. Let's have a look at Barb here. I must be at least 2¼ times Barb's weight, which means I'm probably a little stronger. Come up with your shoulders, Bob. Hold them there. Keep them there. Now, here I am. There is no way that I can overpush her shoulders. What does she need to do? Shoulder shrugging exercises. And any patient you get shoulder shrugging exercises for, you try them, and they're not weak. It's this whole postural business that's wrong. You know, so we go in and we see people in a lift, you know, it's not like this. And perhaps even go to the gym with those machines that you can do this to. Oh, a load of rubbish. This analysis has to be done, and I reckon we're the only people that do this well. So here, just let's finish this off. Hyperactivity of the pectorals produces round shoulders, forward drawn shoulders of the neck and head. Weak deep neck flexors and short extensors produce hyperlordosis of the upper cervical spine. And in addition to the relative movement patterns, the respiration stereotype is usually affected. I'm not sure what he means by the stereotype, but it's certain this, isn't it? That if we get into this position like this and we breathe in, deeper, nothing, deeper, then I do this, I can increase it by 1/3. Just by going into a decent position. And if I'm in like this, there's no way. My breathing patterns are pitiful. And we need to deep breathe, don't we? We need at least to be able to ventilate properly. So we're talking in this terms of the upper cross syndrome and its relationship with chronic cervicothoracic problems with a major, major syndrome, both in its total global effects on a patient. Did I ever tell you about my Alexander experience? I was so mad about this, actually, I was dead slow. If I'd been a bit smarter, you'd have been watching it today. I was flicking through the channels with my zapper because all I could get was bloody hockey. It was like at the playoff times. Every channel had hockey on. I was getting really quite agitated. And I got to our educational channel. I knew there wouldn't be hockey on there, but it might be some opera or something. Okay? And there on this channel was this guy, and it was a very dark picture, and it was like a video of somebody in a black suit with very grey hair and looking very thin and very frail, working on people's necks like this. And I got so carried away with this, I forgot to hit my VCR to take this. And this was some footage of Alexander actually doing corrections. You know Alexander, his story, he was an actor who used to go about the world giving Shakespearean soliloquies. And he lost his voice, and he went to all these kind of speech people and ENT people, and nobody could help him. Why did he lose his voice at critical points when he was delivering these speeches? And one day he was watching himself in a mirror, and he saw that when he went into a particular pattern, he lost his voice. And when he stepped out of that pattern, he didn't lose his voice. And as a result of that, the whole of the Alexander system was developed, and it had a fantastic following in the 20s and the 30s, and there's still Alexander therapists about now. You know, people like George Bernard Shaw and Aldous Huxley, some of the great thinkers, were very much into the Alexander kind of treatment. And he had his clients, not like we do for 300, 3 weeks, that's all you can have. They used to go for perhaps 18 months or 2 years. How could you change this in 3 weeks? How could you? You can't, can you? This is much more pervasive than that. And all those people out there with this kind of thing here, lack of breathing, poor old shoulders, compensation board not admitting that they have got a repetitive strain injury because they don't recognize it, because there was no point that they injured themselves, no individual area, okay? And they're all set up for this. All set up for it. So, what Alexander was doing, I think we could perhaps add to a little bit, because I don't know that he did a lot of specific mobilization to this, although axial extension was very much part of his routine to gain what he called postural homeostasis, a balance, a postural balance. But it takes a lot of time. And if you've got people, we should be having a look at things like breathing patterns, which we've got from Rocabado, that people that have got primitive sucking reflexes and swallowing reflexes can't get back here because you can't swallow your saliva. So you come back here to the original where you're going back to your primitive sucking reflex. So that's all got to be corrected. How you could spend the rest of your life on one patient. So this is a very important area for us to treat. And remember, the rule that we have here is that if we've got postural dysfunctional muscles, it's absolutely no point in trying to strengthen phasic muscles, which are their antagonists. So if we take, let's say, the tight ones, such as the suboccipital muscles, absolutely no point in trying to strengthen the short neck flexors, because they're inhibited. One of the things that Yanda did, a very, very important study in patients with resivity of backache, he showed that these people, when they did a sit-up, got as much back extension activity as abdominal activity. Now, what's all that about? Inappropriate recruitment of muscles. You shouldn't be using your back extensors when you're trying to sit up. When he stretched them, did nothing to the abdominal muscles, the back muscles became quiescent and the abdominal muscle contraction improved. So we've got to be doing stretching, we've got to be doing slow stuff, as well as specific joint mobilization. So these are some of the things that we should be thinking about, that the sort of suboccipital muscles, which are counteracted by these, we've got to stretch those before we try and work these. We've got to stretch the suboccipital muscles before we try and activate the rectus capitis anterior. And there'd be no point in manipulating the craniovertebral area unless we've done some work on these muscles, because it'll just go back to this. It'd be pointless exercise. And so all of this is so important for us. Now then, here's another little point. In terms of thoracic outlet, has anybody seen many male patients with thoracic outlet syndrome? Mostly female patients that I seem to see anyway with this. And why is this? Well, here's a possible explanation for this, taken from an article that I obtained from about 1950, the origin, I apologize, I've forgotten, that we look at the sort of original development of the rib and the rib angle in the child, and then in the male, the angle changes a little to that. In the female, it becomes much, much more acute. That's a natural postural pattern, so that the angle of the rib goes much further down, which lessens the space between the anterior and the middle scalene, squeezing the subclavian artery there. And if you add that perhaps to a middle-aged person that's perhaps putting on a little weight, that the breasts are pulling down a little bit, as well as this sort of slight tightening of the pectoral muscles and all that kind of stuff, then it's going to add to this whole business of thoracic outlet. So thoracic outlet really is another way of saying we've got to treat the whole of the craniovertebral complex in all its major manifestations. And this ain't anything to do with shoulder shrugging exercises. It's to do with a whole pattern of changing a person's function. What a challenge for us. What a challenge.
I think you just said craniovertebral, you have to work on the whole craniovertebral region.
Yes, I think so. And the cervicothoracic. Yeah, the whole thing down. Yeah, the whole thing down. I mean, if a person hasn't got much up here, we would sort of assess it and see how they would correct themselves. And of course, we're going to break it up into just looking at the cervicothoracic junction this afternoon, because that's the bit we're going to be learning the techniques for. So, very, very much of a challenge here. Now then, what I'd like to do is to just look at 2 or 3 techniques that might be quite helpful as far as the cervicothoracic junction, looking at C7 on T1, just to sort of start with. Now, the techniques of manipulation that we've done, the glides and all that sort of stuff, are quite relevant for this area. So let's try and establish a few principles. One is that if we're working C7T1, it's very useful to fix the shoulder girdle. That stabilizes the upper thoracic group. On the other hand, if we're working into the upper thoracic segments, we've got to leave the first, second, third, and fourth rib free to move. Otherwise, if we keep them stuck, it's going to stop the motion of the upper thoracic vertebra. And I think a lot of the time we have patients laying on their side laying on the shoulder, and what's happening is we are limiting the movement of the upper thoracic spine by stopping the movement of the upper ribs. So, let's see where we are with this. Okay, Sandy, come and lay on here. You look as if you could lay down here and enjoy it. Just laying on your back for a minute. Okay. Let's talk about gliding for a minute of the C7 on T1. Just gliding. And I could take this glide movement. I'm looking once again, we've got our principle of the facet joints in a line with this opposite eye. That doesn't change in terms of any positions or anything like this. So I could hold Sandy down like this to sort of stabilize the upper thoracic area there, and I could just pull my hand upwards towards the opposite eye and just mobilize that C7 T1 in that way. Just sort of pull the thing up like this. And this is not a bad way, but it's certainly, I don't think, the best way. Here are two very satisfactory alternatives to this. Could you lay on your stomach and then come up onto your elbow, so you're kind of resting in this position. So we'll put Sandy in this position here and come up a little bit towards the end of the table. That's great. Now, I can come over this facet joint now on the right side of C7. I can know that this is all being fixed more or less by the position of the arm on the first rib. I can take up a contact on the right side of the spinous process of T1, and I can pull now C7 forward in its correct plane for rotating. So my hand is fitting around the facet joint there. My body has got hold of her head, and I'm just pulling it forward like this towards the opposite eye. So this will get the forward cranial gliding movement. Now, my right hand is on the right hand side of T1, stopping T1 rotating to the left, spinous process to the right. I'm just blocking that. So I've got really quite a lot of control there. Now, if you just watch this, and I'll change the direction of my rotation, but just so that you don't get confused by this, I could also come to the other side